Morning, everybody. Thank you for coming. Just wanted to remind you as we start this clinical trial spotlight session to please silent your cell phones. We expect many of these sessions to be at full capacity, so if you do have bags and you see people waiting on the outside to get in, please put your bags on the floor and make room. And without further ado, I wanted to start with our first speaker, Dr. Don Kohn, who's going to talk to us about gene therapy for X-linked chronic granulomatous disease. Thank you.
Thank you, and good morning, and welcome to Chicago, my hometown. So I'm going to present results from clinical trials of gene therapy for X-linked chronic granulomatous disease. This is my conflict of interest statement. So the disease, chronic granulomatous disease, was first described in 1959 by Bob Good, who's the father of clinical immunology, reporting a case report of a patient with a fatal granulomatous disease. About 8 years later, they discovered that the defect was in phagocytic white blood cells. And so what we now understand is that CGD is a primary immune deficiency resulting from the absence or malfunction of NADP oxidase subunits in phagocytic cells, which include neutrophils, macrophages, monocytes, and eosinophils. And these patients have severe and recurrent infections, especially with Aspergillus is one of the most troubling organisms, staph, serratia, other catalase-positive organisms. They may also have inflammatory bowel disease like autoinflammatory complications and hyperinflammation. Estimated incidence is about 1 in 200,000 births in the U.S. X-linked form is most common. There's also 4 autosomal recessive forms. And carriers who are of the X-linked form who have skewed X inactivation and less than 10% oxidase-positive neutrophils may have infections. So that defines a threshold for a target for minimal correction of cells in our patients. So this slide shows on the left the components of this neutrophil oxidase complex. Upon activation of neutrophils, the complex assembles at the plasma membrane and basically converts oxygen to oxygen radicals, which bleaches the bacteria and fungi to death. The GP91 subunit, which is on the X chromosome, but the CYBB gene, is the gene that's defective in the X-linked form of CGD, and that's about 2/3 of the cases of this disease. And patients have severe infections. This upper left panel shows the lung of a patient with mulch pneumonitis, where they've inhaled Aspergillus spores working in the garden, leading to this mold-like infection of their lungs. On the right, you can see hyphae, very abundant in the lung tissue. And the lower left shows one of the characteristic granulomatous lesions that occur in the inability to clear the infections completely. And the patients go on to have severe recurrent infections and develop horrible-looking lungs, like are shown in this patient who's 34 years old, who's had multiple infections over the course of his life. So gene therapy has been evaluated for this disease multiple times. The early studies in the 1990s using murine gamma retroviral vectors and no cytoreductive conditioning only led to transient appearance of oxidase-positive neutrophils. These were shown to have corrective activity of the function, but they didn't persist in the absence of conditioning, but there weren't any adverse events. Later studies performed in the last decade using murine gamma retroviral vectors again, but giving what would be considered reduced intensity conditioning of busulfan at 8 to 10 milligrams showed some effect. So the studies at the NIH, there was a modest percentage of oxidase-positive neutrophils early with clearing of infections. And 2 of the patients have low level but long-term marking, and there were no adverse events. One patient who did not get any long-term corrected neutrophils went on to die, in fact, of infections. And then subsequently a study done in Europe using a spleen-focused forming virus gamma retroviral vector found initial clearing of infections, but an increasing percentage of oxidase-positive neutrophils. And in fact, the patient developed myelodysplastic syndrome from insertional oncogenesis in 3 of the 3 patients treated. And so with the evidence of efficacy but the genotoxicity from the gamma retroviral vectors, investigators in Europe went on to develop this SYN lentiviral vector. So it expresses the GP91 cDNA under the control of a chimeric myeloid promoter with the idea that it would express in the mature neutrophils but not be active in the stem cells where it could cause problems. And a lot of preclinical work was done, showed increased expression with increasing myeloid maturation in the murine XCGD model. And the right shows expression by flow cytometry of this protein because it's detectable on the surface in normal donors, in cells in the middle from an XCGD donor showing absent expression, and then in cells by the patient treated with this vector in vitro, now showing expression of GP91. And so clinical grade versions of this vector have been made by Genethon and Ypsilanti that are used in the clinical trial. Additional preclinical data looked for safety, and they compared this SYN lentiviral vector to the prior gamma retroviral vector and saw significantly less clonal dominance in murine cells in the IVIM assay. And comparing mice grafted with these cells, there was more polyclonal engraftment with the lentiviral vector than with the gamma retroviral vector. And mice treated with this vector showed no unexpected pathology followed up to a half a year. And so based on those preclinical studies, studies were launched in parallel in the UK and in the US. And so in the UK, the studies were done at University College London, Great Ormond Street Hospital, in the US at Mattel Children's Hospital, UCLA, Boston Children's Hospital at Harvard, and the NIAID in the clinical center at the NIH. As I said, the vector was made by Genethon and Ypsilanti, and vector integration site that I'll show you was done by Rick Bushman at University of Pennsylvania. So the methodology, the eligible subjects, the plan is to enroll 5 in the UK and 10 in the US. We'll undergo CD34 isolation and transduction with the G1 XCGD lentiviral vector. Cytoreductive conditioning will be given with pharmacokinetic adjusted busulfan, followed by autologous transplant of the gene-corrected cells. And on the trial, the patients will be followed for 2 years of active follow-up. And so this study has primary objectives of safety, and then also determination of efficacy and stability by biochemical and functional reconstitution in progeny of engrafted cells at 12 months, with additional secondary objectives to assess immune reconstitution, transduction and engraftment of stem cells, assessment of the general health, and then an exploratory objective, we will look at the microbiome before and after treatment. Those samples are being collected and archived and will be all analyzed at the end of the study. Eligibility criteria for subjects 23 months or essentially 2 years and older who have to have a confirmed diagnosis of X-linked CGD and a history of severe problems. So these are all, as I'll show you, all the patients have really significant histories of infections and inflammatory complications. They cannot have an available 10 of 10 HLA matched donor, no co-infection with multiple organisms, and informed consent provided. So the cells were treated in different patients by 2 different methods, either fresh cells shown here or frozen cells on the next slide. So in the fresh cell protocol, a backup is collected at least a month in advance from either a bone marrow or a mobilization and stored, and then the patient is again mobilized with GCSF and plerixafor to collect cells to make the drug product. The cells are CD34 isolated, pre-stimulated, transduced with 2 hits of vector, and given to the patients fresh. While the cells are being processed, the patients are undergoing cytoablative conditioning with busulfan that's PK targeted at 70,000 nanograms per mil per hour. In the fresh schema, the patients are mobilized once with multiple collections. So they're given GCSF and plerixafor, 2 or 3 days of leukapheresis to collect cells, which are then isolated, transduced in the exact same procedure as for the fresh cells, but cryopreserved at the end of the transduction and fully certified for release. Once the product is available, the patient is then readmitted for the transplant, getting the same busulfan conditioning and thawing and cell reinfusion. And so to date, I'll show you the results on 9 subjects enrolled, 5 in the 3 US sites and 4 at the UK site. So this slide lists the 9 patients who've been treated. So they've ranged in age from 2 years of age, the youngest, to 27 is the oldest. You don't need to read the whole list of infections, but they've all had multiple infections, and the word aspergillus recurs frequently throughout their past medical history. And on the right was their status at clinical transplant. And so of note, the first patient and N105 second from the bottom were really sick at the time of transplant. So the transplants were almost done as rescue attempts for their really severe infections. And one other subject, UK02, because of their infections, was on an antibiotic linezolid that's associated with myelosuppression as one of its complications. So this slide shows the data from the drug products that were made for the 9 patients. So the CD34 doses range from 5 to 32 million CD34 cells per kilo. The vector copy numbers in the product range from 1 to 1 being up at 5 copies per cell. The percent PCR positive CFUs were about 50 to 80%. GP91 Fox was lower, probably because the vector wasn't being expressed in the more primitive cells that haven't undergone myeloid differentiation or able to express the vector. This slide shows the busulfan area under the curves measured from pharmacokinetic analysis of their serum levels after treatment, showing that all the patients came very close to the target of the red line, which is the 70,000 nanograms per mil per hour. This slide just illustrates the clinical neutrophil course of one of the patients treated. And so you can see they came in, they got mobilized, their white count went up to 30,000. They were then leukapheresed to collect the drug product, then conditioned with the busulfan and received the transplant. So this was a patient receiving the fresh protocol. And then you can see by about 7 to 10 days, the neutrophil count dropped to 0, as would be expected after a completely cytoablative conditioning regimen. But by about day 15 or so, neutrophils are coming up, and the patient was discharged to home at day 24. And that's pretty typical of the courses for the patients. The only complication really, besides the intended myelosuppression, was mucositis in most of the patients. So this is now the data. This is an assay called the dihydrorodamine, or DHR assay. DHR is a fluorogenic dye which is converted by oxidation to a fluorescent form. And so when neutrophils are activated, they will convert this dye to a fluorescence if they have an intact neutrophil complex. So going down the left is a healthy control. The top two panels are unstimulated, showing just a small peak of activated cells, whereas the bottom panel, the cells have been activated with PMA, and you can see that all the neutrophils essentially are converting the dye. Then on the right is the first signal we got from the US trial. This is the patient at Boston 20 days out. And then you can see with activation at the bottom right, 35% of his neutrophils were reducing the dye. So these then are the data on the 9 patients, showing their cell doses, their vector copy number, the time since treatment, and sort of their current clinical status. And so unfortunately, 2 of the patients died shortly after transplant. So the 2 I highlighted, the first and the second from the bottom, who were very sick at the time of transplant, died. The first one from ongoing lung inflammation. The bottom one, who had had multiple granulocyte transfusions, was refractory to platelet transfusions, was profoundly thrombocytopenic and had an intracranial bleed and died about 40 days after the transplant. The other patients are clinically well to the present time with no severe infection since the time of treatment. So this slide shows the DHR results. I showed you the first time point on B101. So these are all the measurements we have to the present time. The red line is that 10% threshold defined by carriers is probably the low level you need to be above for efficacy. So you can see that all the patients shown here except one are above that level. The one patient who dropped over time was the one who I highlighted who had been on that antibiotic linezolid at the time of marrow harvest or mobilization, and we speculate that that may have affected the stem cells. However, more importantly, the other 6 patients shown here are all with stable levels of neutrophils above that threshold that we expect for clinical efficacy. And this is then in the same patients looking at the vector copy number in their granulocytes. And we know from other investigations that the copy number in granulocytes is a very good reflection of the copy number in engrafted stem cells, because the granulocytes have emerged from the marrow just in the last few days and are very much similar to the stem cell marking. So again, except for those 2 patients who dropped, you can see that all the patients have vector copy numbers between about 0.5 and 2, and they're relatively stable over time out to 2 years in the longest patient. This is a little small, but this is 6 of the patients looking at marking by individual lineages. And the main point is that all the lineages have about the same level of marking over time, with the one exception being the purple lines, which are T cells. So the conditioning of busulfan is myeloablative, but it isn't lymphodepleting. So in fact, they have not, although they're not lymphopenic, they haven't made a lot of T cells. And I think this reflects their age and decreased thymic function. And then Rick Bushman's lab has now been doing the vector integration site analysis. And this shows what's graphed here is the number of individual distinct integration sites isolated each of the time points. And you can see that in most of the lineages, the patients have around 10 to the 4th different integrants, so highly polyclonal engraftment. Again, the one line that's lower is the T cells. And so out of the total analysis to this point, 65 million sequence reads identified 374,000 unique integration sites. And the pattern is highly polyclonal in all 4 patients with no major clonal expansions, with integrations of genes near genes of concern. And so overall, the outcomes, there have been no vector-related adverse events. No replication-competent lentiviral vector has been detected. There are no clonal expansions. Further integration site analysis is obviously ongoing as we follow the patients. And we've collected samples pre- and post-gene therapy for microbiome analysis that will occur at the end. And so then in summary, we report on a novel lentiviral vector using myeloid-directed expression of the CYBB gene for HSC gene therapy in 9 patients with severe XCGD. And as I said, there were no vector-related complications. 2 of the subjects died less than 3 months post-transplant from pre-existing disease-related complications that were present at the time of transplant. But all the patients surviving more than 3 months post-gene therapy cleared pre-existing infections, and 2 of them are off all prophylactic antibiotics at the present time. 6 of the 7 surviving patients have oxidase levels of 10 to 20% or higher, expected to protect against severe infections. And I didn't show you the data, but the GI inflammation present in 3 of the affected patients has also cleared after gene therapy. And so future clinical development will be discussed with the regulatory agencies on this work. So I just want to close in by thanking everyone involved in the work and the people at all the institutions I highlighted, and then also Jenathan and Yepiskesi, I pronounced it differently all 3 times, and the funding from the California Institute for Regenerative Medicine, the NHLBI Gene Therapy Resource Program, NIAID's intramural program, NET for CGD, which was a EU consortium that initiated the trial in Europe, and the Wellcome Trust that supported the work at University College London. And gosh, thank you.
So we have some time for questions. If you could please come to the front with the microphone. Don, I have a quick kind of process question, just because the field has evolved so much. Is each of the individual sites transducing the hematopoietic stem cells and then administering to the patient, or are the cells themselves being processed at a central?
Yes, so in this protocol, all manufacturing was local, and so we had a common SOP. In fact, we had a monitor who reviewed all 3 sites. She initiated all 3 sites and did ongoing monitoring of the processing. So we processed at all 4 sites, but we think it was very consistent.
Very nice talk. Just a quick question about the DHR assay where you see lower activity in the transduced cells. So do you know how that's going to change the threshold of engraftment rates that you need for your lentiviral transduced hematopoietic stem cells to get good efficacy?
So what I showed being lower in this drug product was the GP91 flow. And I think that just reflects it because the promoter is mainly active in mature myeloid cells. There's less expression of the primitive stem cells because that's the CD34 graft. Those weren't differentiated. I see. So I think it's really telling us that that's maybe not the best way to characterize potency of the cells.
Thanks. Very exciting results. Can you comment on fresh versus cryopreserved cells?
Yes, I think we don't really see a difference in the engraftment or the outcome. We are moving essentially completely to cryopreserved, just because right now we've been conditioning. With the fresh, you're conditioning the patient before you have the drug product. So there is a backup, but it's still at risk. And with the cryopreservation, you have the drug product completely secure before you start conditioning.
That's great.
Yes.
Good morning. Nice talk, thanks. I have 2 related questions. First, what criteria are you using and how closely are you following the GI inflammation reduction? And secondly, how deep are you going on microbiome analysis over time, metagenomics? Is it a crucial part of the follow-up?
So in terms of the GI, we're just using clinical conditions. So the NIH and the investigator, Harry Malik, who's one of the investigators of the study, has as much experience as anyone in the field. So we're just using sort of clinical assessment of it.
Like a Mayo score or something like that? Bleeding?
Yes.
Are you doing endoscopy?
We're not prospectively, only if clinically indicated. And the second question was?
About how deep your analysis is going on changes in the microbiome.
So I know the plan is to do 16S RNA analysis, and I'm not sure what else Rick's going to do. We have all the samples stored, and that's going to all be done once we have everything so it can be done in one large single run, basically.
So I have a quick question for you. The age of the children, you don't do this until post 23 months of age. Mm-hmm. So all the SCID gene transfer seems to work best in very young kids. So why do you wait? I mean, is it because the disease isn't diagnosed until that age, or what? And do you think it would work better if you went earlier in life?
Yeah, so I don't know if I accept the premise that ADA or SCID works better in infants. Some of that has been bone marrow versus mobilized peripheral blood, so you get less bone marrow cells in the older patients. But part of it is, as you said, there isn't newborn screening, and so typically patients aren't picked up unless there's a family history till they're a year or two old. And because of the requirement that they've had severe infections, they really need to have to declare their disease, and so 2 years of age was chosen as that time point.
Okay. Last question.
I wonder why the DHR test results are, for example, 50% or 30%, whereas you have VCN, which is 1, for example, or above 1 even, in granulocytes.
Right. So I think, there's a Poisson distribution of the vector, and so if the average vector copy number is 1.0, in fact, not 100% of the cells are transduced. Some of them have more than 1 copy. And so I think it reflects the percent that have 1 or more copy.
Okay, thanks, Tom.